Okay, well, good morning, all. What we want to do is talk about a situation. This was a case that came to one of our clinics actually just in the last 2 weeks, and it represented an interesting challenge we have where patients will come in with a vague injury and pre-existing problem, and sometimes hard to know what of the symptoms they're having. Are they more related to the pre-existing problem? Are they more related to a new problem? And those pre-existing problems may be, not infrequently, non-job related pre-existing problems. And sometimes they'll come in having had a pre-existing job injury and now it's worse on a non-industrial basis. So how do we make our way through this and figure out how to deal with the condition that presents itself in the clinic? Scott, you can do the next one. So what we want to do is talk about a patient suffering concurrent industrial and non-industrial medical conditions. How do we assess this and then set ourselves on the correct management plan and path? I'm not going to talk about the treatment, just really it's the early assessment, because in the first visit, ideally, we need to make a decision as to what we're dealing with. Is it industrial or not? Or sometimes this also applies to pre-existing non-industrial and then a non-industrial exacerbation. And the sort of place I see that is patients with come in as an urgent care patient and they've got a pre-existing problem and then they've had an MVA or there's a slip and fall in a market. And so we're making these kinds of decisions both in the work comp and in the group health marketplace. Next slide, Scott. So here's the deal. January 2nd of this year, patient had an injury and came into the clinic on the 6th, 4 days later. Reports he's a mechanic, we're performing his normal work duties, including occasional kneeling and lifting, carrying tires. A number of things can be fairly heavy. Next slide. Patient does not recall a specific event to trigger the pain. Reports an ache in the knee that started midday, causing him to elevate his right knee during lunch. Patient was able to complete his work date. So onset of pain or worsening of pain during the day, during the work day, nothing specific, but it happened while he was working, doing strenuous activities. Next slide. So he noted on the evening of the injury that his knee swelled with increasing pain. He called off work the next morning, the 3rd, because of the pain. Then he had the following 2 days off, the 4th and the 5th, and then he called off on the 6th, and that was the day that he came into the clinic. Next slide. At the time that he was seen, he rates the pain as 4 out of 10. He knows the pain is increased after standing from a pre-existing experience, improved slightly after 10 minutes of warm-up. He reports the knee feels weak, been using a knee brace and crutches to ambulate. Patient reports taking ibuprofen and Tylenol with mild improvement of his pain. Next slide. And so he has a history of bilateral knee injuries with some arthritic changes noted in the past with daily aches and pain prior to this injury. Patient knows he's got a history of chronic gout, typically occurring in the upper extremities and toes. And these are quotes just out of the medical record. Next slide. And then on exam, tenderness along lateral and medial hamstrings, back of the knee, significant swelling along the medial quad above the knee with minimal tenderness. So that's the picture when the patient came in historically and from a physical exam standpoint. Next slide. So what is it we need to gather at this point? If patient comes in, you're looking at that, what is it that we need to, what do we need to know at this point? Next slide. So the first thing is, did something actually happen on the job? And the information's a little lean in the chart, but it seems that there wasn't anything specific that actually happened on the job. And bear in mind, in workers' compensation, it's, as you know, an AOE, COE decision arising out of employment and in the course of employment. And actually in the labor code, it's the burden of the patient to demonstrate that injury occurred. Now, as a practical matter, it doesn't always work out that way. And sometimes the burden ends up being on the employer to disprove that an injury occurred. But AOE, COE, something actually happened to a part arising out of, so there's a causal relationship. There needs to have been something identifiable that happened on the job. And then COE in the course of employment, which is the temporal aspect. So there's a causal relationship, something happened, and a temporal relationship. Whatever happened in a temporal relationship to the work, not after the job at another time. So we need to do our best to gather that information from the patient. Now, in this case, it was a little bit vague, and apparently the patient couldn't identify anything in particular. Next slide. So the next piece of information in a situation like this, what was the pre-existing condition excuse me, and work status prior to the injury? We need to know more about the patient's pre-existing condition. Sorry. And what was going on prior to the injury? What conditions did he actually have? Gout, was he being treated for the gout or not? Prior knee problems, did he have some sort of pre-existing or injury that occurred previously? Did it involve both knees? What is his doctor, whoever treated him for these before, telling him about his condition? Was it thought to be that the pre-existing condition was job related? Did he have an industrial injury and now he's got residuals? Did he have non-industrial problem thought to be perhaps osteoarthritis and pre-existing from that? So it's hard to know, and particularly then if we can quantify what his condition was before. So oftentimes on a 10 scale, pain, ask the patient, of course, as we often do, what numerical designation of the severity of the condition that he had, his symptoms. What sort of treatment was he getting? To determine as much as possible about how he was doing before this purported injury or event occurred. Next slide. And then trying to determine then his complaints, current complaints, and presumed to be job injury. Again, was it a specific injury? In this case, apparently not. Was it thought to be somehow a cumulative injury? And that's something we often count on the patient to tell us, knowing more about his job than we do, his or her job. So was it specific? Was it cumulative? Or was it, again, pre-existing? It seemed to be in this case. We need those pieces of information to make judgments about making an AOE, COE decision. Next slide. And then finally, what's the current status of his knee, his work status? What pain number would he assign to it? What are the descriptors of his problem would he offer us that gives us some sense of how he's doing now compared to how he was doing before the purported event occurred on the job? Next slide. And next slide. So, and hit it one more time. One of the decisions then that flows out of this is, and we've talked about this previously, does what he has constitute an aggravation or an exacerbation? Aggravation is a magic term in work comp that means something got worse from a pre-existing problem. Exacerbation means pre-existing problem is just worse because it tends to wax and wane. So if you look at the graph that we've seen many times before, the A line is how the vast majorities occur. There's time on the x-axis and y on the signs and symptoms are on the other. And so the A graph demonstrates somebody that at time zero had no, in this say pain, whatever the symptom is, rises to a maximum and then resolves and the patient's fine. B graph is when there's then represents the pre-existing problem. So patient has whatever injury, symptoms rise to the level of just under 7, and then becomes permanent and stationary, and the problem, the symptoms wax and wane. The pain's more one day or 1 hour or 1 week, and then less the next, and it goes back and forth. And then the C graph represents the aggravation that occurs, and perhaps that's what happened here. So patient had pre-existing problems, and now they're worse. For what reason? And so if it's thought that there's a new injury that occurred, then that's an aggravation, and it's a C graph. It represents an increase in symptoms. Or are we interpreting this really as just the predictable waxing and waning of the pre-existing problem? So we need to make that decision, whether it's an aggravation or an exacerbation. And we also want to quantitate this to the degree possible. The terms in workers' compensation, probable means that the likelihood that the event we see, and referring now to an aggravation, is probable. It's greater than 51% chance, more likely than not, that this is a bona fide aggravation. And that's in contrast to it's possibly an aggravation, which means less than 50% likelihood. So we want to state whether we think this is an aggravation or exacerbation, and is our decision about that probable, more likely than not that that's actually the case. And then how do we make that decision that there's a material change? And how do we measure any material change? So let's go to the next slide. What is a material change? It's an increase in some cases, in fact, most cases, there's an increase in the severity of symptoms. So the pain is worse, the numbness or tingling is worse, the weakness is worse. Whatever the pre-existing problem is can it be quantitated, and is it now worse than it was before? And it's important to comment on all of these, not only in the decision-making process, but eventually when the patient is P&S in the end and does not return to whatever their baseline was prior, their pre-existing baseline. This is going to be the basis for apportionment. So we want to comment about the extent of severity, increase in severity of symptoms if they occur. Next slide. Increase in severity of physical findings. Is there now the range of motion perhaps in a shoulder is less than it was before? Flexion, abduction, whatever motions, movements, joint movements, is that diminished? Is the severity greater? And so we want to try and determine if that's the case. That assessment influences our decision about this being an aggravation or an exacerbation. If there's really no change in symptoms, if there's really no material change in physical findings, that isn't leading towards the conclusion of an aggravation. Next slide. Use of medication. If the patient was taking pain medicine or some other medication prior to the purported new event, and now is increasing that amount of medication because the pain's worse, then that's significant in terms of determining that there's a material change. Next slide. Use of therapy. If the patient had a settlement, was getting occasional physical therapy, or maybe not getting physical therapy, but now needs therapy, there's a change in treatment, and that signals a material change in the condition and supports the conclusion that aggravation is what's occurring. Next slide. Use of assistive devices. This patient was using knee support and crutches. We don't know if, I'm assuming that that was not the case prior to this event. Hard to believe that a mechanic would be able to work with crutches, but now seem to be using crutches. And so that supports the idea, the conclusion potentially that there was a material change. Next slide. Work restrictions. Patient had permanent restrictions, perhaps from a previous condition. Now those work restrictions have increased. previously had a 20-pound lifting limit, and now you determine really needs a 10-pound lifting limit, or was able to do repeated weight spending before, but now can't, or whatever other restrictions you're going to apply. If that represents an increase over any prior work restrictions, that's significant indicates a material change. Next slide. Need for time off work or change in activities. So now does the patient need a brief period of time away from work, or is the employer going to reassign the person to another job that potentially the employer would call normal work or restricted work, but represents effectively an increase in restrictions on work? Is that happening? And either of those would suggest there's a material change in the condition. Next. And then just other, there may be something else that represents a change. So when you're trying to decide if the patient's current symptoms constitute an aggravation, an increase, these are the places you look to justify that conclusion. If there isn't really any material change in any of these things, excuse me, then we more reasonably consider this to be an exacerbation that is just part of the predictable waxing and waning of the symptoms that were there prior to whatever event was thought to have occurred. Next slide. So what do you think in this case? Next slide. So what's the working diagnosis, which is not the presenting symptom? Anybody covered quite a bit of territory. What, you're faced with this in the clinic. Anybody have a suggestion as to whether you think this is an aggravation, a new problem, or is it an exacerbation of a pre-existing problem, or do we really not have enough information to make a decision? What envision yourself in the clinic, and this comes before you. What are you going to conclude at this point? Any takers?
Steve, I'll throw my 2 cents in here. I think that actually was a really good presentation. I love when I see that chart of I'm finally starting to understand, I think, the aggravation versus exacerbation. And but I'm wondering if just 4 days after this initial complaint of pain, do we know where that graph is going? Is it too soon to even actually make the decision? I guess that's what I'm not sure. If I had a month of symptoms and so forth, I could see which curve the patient's on, but 4 days, could it just be a spike in his waxing and waning of his knee pain? No. So I guess that's my question. I'm not sure if we can tell right now.
Yeah, that's a really good point, Scott. My sense of it was, in looking at this, that if he's now using DME, crutches in particular, where he wasn't before, then that suggests that there's a bona fide increase in his problem. If he had to take a couple of days off work because the pain was too severe, that similarly would suggest to me that he's worse. Now, the question still is, though, is there something that happened on the job to make him worse? Or is it really, as you're asking, is it really just the waxing and waning of his pre-existing symptoms? And we unfortunately don't know, I think, enough to make that judgment. The question, a thought too here is, when all else fails, again, it's the burden on the employee to demonstrate that there's a positive AOE, COE decision. And as I mentioned, it doesn't always hold. And in many cases, the burden's often on the employer to disprove it. But we start from what's in the labor code, and that says arising out of and in the course of employment. And in the absence of any specific event, I'm not inclined to think that this is really a job-related problem at this point. Let's go on to the next slide. So my feeling would be initially to call this non-job related. The other option would be, which I reluctantly do, and confined to limited situations is to, when we have to click, one of our choices on work comp and making a work comp, job causation decision is really to defer on this. Now, if we had more information from the employee about what his pre-existing problem was, I think it would be easier to make that sort of decision. But in the absence of something specific, I'm inclined to think, at least at the outset, that this would not be considered job related, but would be the waxing and waning of pre-existing problems. But that's really a soft conclusion. Now, recall also, one of the nice things in work comp is you don't need to convince a jury of 12. What you do is you just simply make your own best decision about this. And the conclusion needs to be supported by the strength of your opinion that it's more likely than not. And so a way to word these often is, in the absence of whatever happened on this day, he wouldn't have been worse. Meaning it's a pre-existing, it's the pre-existing problem. But let me take that back. In the absence of whatever happened on that day, in other words, if it hadn't occurred, now this really applies more to a specific injury than something vague like this, then that would tend to suggest that there was an industrial problem and it's an aggravation, but there's nothing that really happened that I could see on this, and I'm inclined to think non-industrial for the time being, but it's a soft decision. Next slide.
Steve, I have a quick question. Just
Yes.
sorry to interrupt, but
No.
On the work status flow sheet, you mentioned earlier, like one of the first questions is, is this job related or not? And currently we have two boxes, yes or no. But in addition to those two boxes, there is a comment section right next to it. You can click on the little comment and you can write in, cannot be determined, or, need more information. I guess there is a way we could write in there and instead of yes or no.
That's true. And actually there's one third box that says we can't make a decision at this time, but I think that's worth rewording, because it also says don't fill out don't submit it as a work comp claim. One of the things that we do in these cases is, regardless of what our conclusion is, we fill out the the DFR, the doctor's first report. And that doesn't mean that it's going to end up being accepted as a job injury. In the end, the carrier will make the decision as to whether or not they're going to accept it. And if they're uncertain at the outset, they put the claim on delay. And perhaps you recall that there's 90 days of deliberation, of evaluation, getting the patient's statement, et cetera. So the carrier is not bound by what we decide, but they're substantially influenced by what our opinion is. And so I think our first choice is to always try and make our best decision and say yes or no, but you're right. If we can't, then we type in the narrative text there that we're just uncertain, there's insufficient information or whatever is on your mind that makes it difficult to make a decision at this point. So yes, that's certainly a choice, but whenever possible, if you feel that something's more likely than not, then that should guide your decision. If you just have no sense of the yes or no of it, then that's an option. I agree with you. So there's sometimes a dilemma on these. Next slide. So what to do next? See the question here. Do you discuss with patient that you think case is not work related or just document? I have that discussion with the patient. I tell them that if I think it's not job related, and so I will, when it's obviously job related, don't need to have that discussion. When it's obviously not job related, I will tell them that. And in the situation where I just really can't tell, what I explain to them is, I'm not certain right now, based upon how work comp is. I just can't make a decision. And the carrier will look at this tell them that the carrier will probably put it on delay, take a statement from the patient, and then make a decision. And where this most commonly arises is with job stress, which is perhaps you've talked, you recall some of the earlier discussions we've had. This, in that kind of a situation, it's just really hard for us, not so much because the information's hard to interpret as there's often more to it that requires rummaging around in the patient's psyche, trying to decide what pre-existing problems existed. So, but never to answer the question specifically, if I think it's not job related, or if I am not sure, I'll tell the patient that. And I think this is also part of the business early on in general of setting patient expectations. I think what we ought to be doing is letting patients know where we're going on claims. What's the treatment plan? What do we have in mind? What can we expect, or what's your plan sequentially? This is also one of the reasons with using actual bona fide diagnoses, diagnostic terms rather than symptoms as diagnoses, is tell them what you think's going on, tell them what you think the problems are. The first step is light work and medication, and the second step is PT or whatever, and the next step is, MRI or whatever. But let the patient know where you're going and what you think about their case. Anybody have any other comments or thoughts about that? So next slide, Scott. So what do you do next? Well, you determine what treatment's going to be needed under work comp or group health. The fact is, whatever you think the problem is, the patient's going to need treatment, no doubt. And so you want to determine that. Hopefully you made a decision as to whether it's going to go down the work comp path or the group health path, because we need to direct what we're doing to the right insurance carrier. But the patient has to be treated, whatever you think is going on. Now, in work comp, perhaps you recall, if there's a claim on delay, then under work comp regulations, the payer is required to pay up to $10,000 for any treatment that meets MTUS guidelines, the guidelines we're expected to follow. So even if it turns out to be group health in the end, non-job related, care can be provided under work comp up to $10,000, and hopefully a decision's made during that time if you're uncertain and the claim's put on delay. So we want to start treatment. We don't want to not treat the patient, and we would start under work comp if we're really not sure. So what to do next? Determine what needs to be treated.
Steve, I have a quick question, just to clarify for my own clarification. That $10,000, the patient never has to pay anything back, right, on these? If it's determined not to be work-related, it just switches over to their private insurance or group health insurance, and they move on, right?
Yes, and there's no subrogation, so that the work comp carrier doesn't go after the group health insurance company to retrieve that. This is an expense under work comp. So yes, in fact, it's illegal under a work comp claim for the patient to have to pay anything, although there are circumstances where that ends up happening, particularly with medication. But as long as care is being provided consistent with MTUS, Medical Treatment Utilization Schedule guidelines, then the work comp carrier will pay for it.
Can I go back one or two slides where you asked, like, okay, in this case, what's your diagnosis? What would you put down? I'm still scratching my head on that because I want to say knee strain, but there is no incident.
Right. Well, if I'm going to call this non-job related, and hopefully we would usually have a little bit more information, and maybe some of the records would be available if any prior providers, uses Epic or system that interfaces, and you're looking at your own x-rays, presumably taken, there may be evidence of osteoarthritis. So either historically or on x-ray, that may give you a basis to call it osteoarthritis. If it sounds like historically that's part of what it's been. Gout, not sure what the relationship there was, but had a knee replacement, chronic knee pain. So I'm assuming there's osteoarthritis, maybe a prior meniscus injury, but I would say osteoarthritis again, a soft decision.
Would you have drawn a uric acid on the first day you saw this patient?
That's an interesting thought. That would be a good thing to do. I think it would give you some additional information down the road. The other thing I'll do sometimes, it depends on the relationship with the carrier. We've got some carriers that we work and adjusters we work really closely with. I don't do this often, but I do it sometimes. Is if I've got a real dilemma, particularly if I think there's a really serious problem, I'll call the adjuster and say, you don't have any information yet, but I've got this problem, and just let the carrier know what's coming so they're not surprised. Most of the time, they won't give you much useful information because they don't have a claim to look at, but sometimes I'll do that. But in any event, to answer the question, I think the uric acid would have been a reasonable thing to draw, and then you've got it. One more slide. And here, just a reminder of what we're looking at with the graph, and one more slide. Just the important thing here is work comp, our responsibility is, I think there's a typo there, will be to return patient to pre-injury status, not necessarily resolution of all signs and symptoms. So that is the other reason to have assessed what the severity of the pre-existing problem was. If you're determining there's an aggravation and you're going to treat them, our responsibility is not to cure them, not to return them to a pain-free state, but is to get them back to how they were prior to the purported injury or purported, the aggravation representing a new injury. So that's our goal. It's not total symptom relief. It's getting them back to how they were. So additionally, it's important to assess what that condition was so you know where you're going with your treatment plan. Next slide. And this is to set patient expectations, letting them know all along the way how you see things, where you're going, what they can expect. So they've got a realistic sense of what's going to transpire. And then one more slide. And another slide. So apportionment be considered. I just kind of mentioned there. This is really, now we're running out of time, a subject for more discussion later. Next slide. What reports do we need to send? Next slide. So in this case, it's going to be a DFR. Even if we think it's not job related, we fill that out, send it in. That becomes part of the documentation for this claim. And claim is not, the fact that there's a claim number doesn't automatically mean it's a job related injury. It means there's a claim submitted by the patient to the employer, and a DFR and the employer first report have been sent in. So you always send in the DFR in situations like this. It's part of the documentation of what your thinking is. Next slide. So that's where we've gone with this discussion. Any questions? All right. Thank you for your time.
Really quick, Dr. Schumann.
Yes.
I had a workers' comp patient tell me that she received a bill from her workers' comp insurance carrier. She didn't bring the bill in with her. I did tell her that anytime she gets some paperwork that she's unaware of what to do with, just to bring it in at her appointments. But just off the top of your head, do you know of any reason why an insurance carrier would be sending a patient a bill?
I have no idea, and that's incredible. Was this recent?
Yes. So I've been seeing her since, I believe, August or September, and she received a bill in the month of October, but has not received a bill for the months of November, December, or for this month.
Did they identify?
I'm sorry. I did clarify to make sure that the letterhead was not from Doctors on Duty, and that it was actually her insurance carrier. And she said it was the label from her insurance. But she's gonna bring it in to me, but I was just trying to see if you know of any reason why she would be receiving a bill.
I can't conceive of why that would be the case.
Yeah,
so
me neither.
I would be interested to see the bill and some documentation. And I think, excuse me, she had call the adjuster, if indeed. that's
Yeah, and
what's going on.
unfortunately, she's not able to reach the adjuster, and neither have we been able to. So we're trying to reach out to the supervisor to see if there's an adjuster change.
Good.
But yeah, it was weird because she still continues to get the letters to pay her bill, but she's
Huh.
not able to actually reach anybody to discuss it.
Well, I would be
I don't know.
interested, I'd be interested to know how that ends up. I've never heard of that before.
Me neither, but I'll keep you updated.
Yep, thank you. All right, folks, thanks for your time this morning.